Welcome to the National Dental Association Policy Hour. I'm your host, Dr. Wallace Bellamy, the 102nd and current president of the NDA. Today, we're talking about policy, and it's more than just policy. It's about protecting the future of our profession and the patients who depend on us every single day. What happens legislatively right now will determine who becomes a dentist, where they practice, the sustainability of our institutions, and ultimately whether patients can access care at all. These are not just abstract issues. These are real decisions being made in real time, and they will shape the trajectory of oral health care in this country for decades to come. So we're facing a critical challenge. We're facing proposed student loan caps that could fundamentally restrict who is able to enter our profession. Continued financial pressures during residency that influence career decisions and pathways in specialty care. A dental insurance system that far too often gives patients coverage but not access, and other legislative issues that are relevant to our future. So tonight, it's about clarity. It's about transparency as we frame and align ourselves with information so that we can convene action. And as we prepare for our upcoming Day on the Hill, the NDA Day on the Hill is this Thursday, May the 7th. We must ensure that every NDA member and every advocate is informed, prepared, and unified in our message. So this is a defining moment. And if we want a future where access to care is real, where the workforce is strong and diverse, and where patients are truly protected, then we must engage, and we must be strategic, we must be intentional, and we must also be purposeful. And I can't think of two better voices to help guide this evening's conversation. With me today are two extraordinary leaders. Dr. Leslie Grant, current chairwoman of the NDA Legislative Committee and 82nd past president of the National Dental Association, and Dr. Julie Greenlee Taylor, member of the Legislative Committee, respected policy expert, and the 92nd past president of the National Dental Association. Both bring not only deep expertise, but a steadfast commitment to advocacy, equity, and the advancement of our profession. So let's get started. First of all, Dr. Grant, welcome. From your vantage point as chair of the Legislative Committee, what is the single biggest policy threat or opportunity facing dentistry today?
Thank you so much, Dr. Bellamy, and thank you for the question. If I may, I'd like to just digress a little bit and let everyone know that we are thrilled to invite them to NDA Day on the Hill on May 7th. The registration link is on the website, and our convening will be at the Capitol Visitor Center, and we will be advancing change through policy and power. All right, so, and Dr. Bellamy, thank you for convening this very important policy podcast. Overall, one of the greatest threats to appropriate health care is the rise and influence of pseudoscience. We are seeing specious, inflammatory, non-scientific model recommendations and misinformation impacting the doctor-patient relationship, as well as decaying the trust in scientifically proven treatment and preventive methods, such as vaccine and fluoride. But to answer your question more specifically, one of the single biggest dangers we're experiencing policy-wide is the decimation of aspirations toward an understanding of the need to affirm health equity and a diverse workforce. Equitable health services delivery and research merely aim to accomplish the best individualized health care across the spectrum of society's representation, whether it's gender, ethnicity, age, or disability, or economic status, for example. We have seen disparaging attacks on inclusivity in the workforce. The more diverse and representative our healthcare providers are, the better the healthcare delivery system is for everyone. As far as opportunity, we have the ability to share our presence and concerns with policymakers. Everyone is a constituent of some legislator, and they are accountable to us. We can make certain our voices are continuously heard and take the time to enlighten, educate, and engage with folks who make decisions that affect our patients, our practice, our educational programs, and our lives. These are some of the reasons our National Dental Association's Day on the Hill is so important and timely.
I appreciate that, Dr. Grant. Welcome, Dr. Greenlee Taylor. Please help us connect the dots. How do federal policy decisions actually translate into what happens in the dental clinic or the dental office?
Thank you so much, and good evening to everyone, and good late evening to everyone on my East Coast here. It's a pleasure to be here. Thank you so much for the National Dental Association for this invitation. As Dr. Bellamy and Dr. Grant has already said, it's so important that we all play a role, federal levels, state levels. There's so many different levels where you can actually play a role. I'm going to share a quick slide here as I kind of speak to, let me know, Dr. Grant. Okay. So Dr. Bellamy just asked the question, how federal policy decisions actually translate into what happens in a dental office or clinic. So for those of us that are on the call that are still in clinical practice or provider, even if you're in faculty practice, even if you're in an FQHC, when we think about legislative policies, a lot of the things that we're going up to NDA on the Hill for, Congress actually passes these laws and determine the funding for different things. So don't look at the 1, 2, 3, 4 box real quick, but just when you think about Congress passes the laws and the funding, that's step one. They're the overriding guardian, I guess you can say. And then they may tell the agencies, okay, CMS, here's what we've passed, here's how we want you and to use the funding, and then the agencies actually to decide how to operationalize that legislation. Then once an agency has determined if it's a policy that connects with an agency, then they kind of pretty much flow that information to the states. And then what sometimes people don't realize, yes, federal policies have a lot to do with everything, but a lot of times certain policies, it's the states that kind of determine what type of different nuances they want on that, because sometimes federal policies will give states the opportunity to kind of navigate those policies. If you think about kind of like Medicaid, they put the framework down, but then the states get to decide, for example, if they want to do adult dental benefits, if they want to do child benefits, and then you have commercial insurance. Then it comes to the dental office as the impact. So when you think about some of the things that Dr. Bellamy just talked about, and I think we'll go into a little bit more of these policies a little bit more specific a little later, but who can get care? When you think about insurance and coverage, policy determines who has the dental coverage, what services are covered, patient affordability, and then strong coverage, more preventive visits, weak coverage, more emergencies and delayed care. Think about workforce. You think about federal student loans, you think about loan repayment, FQHCs and all of those things. Who is available for the workforce? A lot of these federal policies determine student debt, where dentists practice, underserved areas are served, strong workforce policy, good access, weak workforce, long waits and shortage. Think about disease prevention or late treatment, public health. Think about CDC, think about water fluoridation, all of those things when you talk about infrastructure on number 4. So when you kind of put all of those things together, with disease prevention, a lot of the funding that comes from federal policies tells CDC and how to do Title V with states. So you put all that together, the policy determines who get care, who can provide it, and whether we're preventing disease or treating it too late. That's basically the bottom line with that. So we play a part in all 4 of those different areas based on what type of policy it is, who can get care, when they can get care, and who's giving them that care.
Thank you for that high-level policy decisions overview. But let's talk about student loan caps and something called the One Big Beautiful Bill Act. On paper, it may sound fiscally responsible, but what are policymakers actually missing?
Absolutely. So, and you just hit it on in a nutshell, really. What are policymakers missing and what are we missing? So when you think about it on paper, loan caps sound fiscally responsible, right? But what policymakers may be missing is that they're just not capping debt. They're reshaping who can even enter the workforce. So the one big beautiful bill, it strict limits on borrowing. Like, for example, some of you may have heard of the Parent Plus bill. So the Big Beautiful Bill caps Parent Plus loans at $20,000 per year, and it's eliminating programs like Grad Plus loans altogether. So that might reduce federal exposure, but it doesn't reduce the cost of education, especially for high cost professions like ours in dentistry. So what actually happens is the gap doesn't disappear. It basically just shifts. Students either take on higher risk private loans. So now they don't have the option of federal loans. So they have to go do a high interest rate private loan. They choose higher paying specialties over community based care. So it's like, oh, I want to be an oral surgeon or orthodontist versus, go work in a public health center because the loan repayment is going to be so high. And then they opt out of sometimes they just opt out of the profession entirely. And that's the part we're missing, that from a workforce standpoint, this could unintentionally narrow the pathway. So particularly for students in underrepresented communities, if they don't have options to these loans and a lot of these loans are capped. If you have 300,000, 400,000 in debt, do you decide you want to still go to dental school? Do you decide you want to practice in a high revenue area, or will you go back to communities you may be born and raised in? So that's what policymakers are missing, that fewer providers will be entering the field, less diversity in the workforce, and ultimately reduce access to care in underserved communities.
Dr. Grant, Dr. Greenlee Taylor may have already alluded to this answer to this question, but what does this mean for the future of dentists who want to serve in underserved communities?
Thank you, Dr. Bellamy. And yes, thank you so much, Dr. Taylor, for addressing in such depth the impact and the specifics around these student loan caps. So I call it the big bill because I didn't see anything beautiful about it, but it is a very, very big bill. And I'm going to give a few more specifics. So this goes into effect July 1st of this year, July 1st, 2026. And the specific impact is that there is a $200,000 lifetime federal student loan cap on those who are in the higher professions, postgraduate professions, such as medicine, dentistry, pharmacy. The lifetime cap is lower for like baccalaureate professions. However, this $200,000 lifetime cap is your undergraduate, graduate, and dental school. And we know that dental school alone far exceeds $200,000. So as Dr. Greenlee Taylor said, this is going to jeopardize students having, and in particular our students, having to pause their careers or forego completing their dental training education altogether. I wrote a few things down because this really concerns me, and I'm saying it in a positive way. It gives me great concern that this student loan cap will be imposed, jeopardizing recruitment and retention of aspiring dentists, particularly those from underrepresented communities. The cost of combined undergraduate and dental education programs typically far exceed this $200,000 funding limitation cap, and the legislation will significantly negatively impact the ability of future professionals to obtain their educational goals. Imposing these student loan caps blatantly favors affluent individuals who are not reliant on subsidies and who have families who can assist with their tuition or can sign for personal loans for them. And many students from our communities just don't have those options. and as I said, may have to suspend their training while in school, or obtain loans if they can that are accruing interest while they're in school, and that they may have to pay on those personal bank loans while they're still in school, which we know is impossible to do. When we're seeking these higher education careers such as medicine and dentistry, we don't have the opportunity to work part-time the way many other individuals are, who are pursuing their bachelor's or postgraduate degrees. So the impact on underserved communities will be greatly unfortunate. We know that underrepresented minority professionals tend to be the ones most likely to treat those who are financially challenged across the spectrum of communities. As indebtedness increases, our graduates will be faced with the dilemma of serving where they are most needed, or where they can most expeditiously address the reality of their monumentally magnified student loan debt due to increased interest. So this big bill, along with being devastating in many ways, certainly has the potential to significantly decrease diverse representation in our dental training programs. And when I say diverse, I mean across the socioeconomic spectrum, as well as gender and ethnicity spectrum. So I hope I addressed, Dr. Bellamy, some additional points. I believe that collectively, Dr. Greenlee Taylor and I are very, very concerned about the impact overall of this aspect of the big bill.
So we're not just talking about debt. We're essentially talking about who actually gets to enter the profession at all.
Yes.
So
yes.
Also, Dr. Grant, we're going to change over to the Resident Education Deferred Interest Act, or the READY Act. It seems like a common sense solution. Why is this so important right now?
Well, first of all, especially in light of what I just discussed in terms of the level of indebtedness, number one, even without the student loan cap, if we take that out of the picture, we know that dental education is one of the most, if not the most expensive educations in this country. And our students, while they're in school, understand that they are encumbering a lot of debt. And when they graduate, they have a lot of debt. Once our students become our colleagues and they are new graduates, those student loans come due. For those who pursued postgraduate training, such as a general practice residency or dental specialty training, the interest on their student loans would continue to accrue. So the Resident Education Deferred Interest Act, the READY Act, this is a bipartisan sponsored legislation that aims to provide some relief to new graduates who are pursuing postgraduate training in dental and medical internships and residencies. The provisions of this bill would defer the interest on student loans during the training periods. And by deferring interest on these loans, our future dental workforce would not be penalized by unfair indebtedness and would be better positioned to serve our communities. Financial disparities are prevalent everywhere, but for us, especially in our communities with our newest dental colleagues, it's incumbent upon us to do the most and the best we can to advocate for lessening this long-term burden, and the READY Act attempts to do that. And it's especially important to recognize that Chrissy Houlihan from Pennsylvania, Congresswoman Chrissy Houlihan, and Congressman Brian Babbitt from Texas, this is a bipartisan sponsored act or bill. So it speaks to the heart of the fact that there are those in Congress who recognize that we need to have a well-trained professional dental workforce. And this is one way to help that workforce feel a little bit of relief while they're pursuing their postgraduate training.
And advocacy on our part will help that out. Dr. Greenlee Taylor, how does interest accrual during residency shape career decisions, especially for those considering specialization or career-based careers, service-based careers, sorry?
Absolutely. And Dr. Grant's hit on a lot of those points with that. But if you think about, and let me kind of add in a couple of other, we're kind of building on each other and piggybacking. The READY Act, which has been around now for at least a year, a couple of years, I've been up to DC quite a few times, and I will say there are a lot of members of Congress that have already signed on or, to co-sponsor this bill. So it is very deep in the hearts of a lot of our legislators where they feel pretty strongly about that. The one thing that we have to emphasize is that the READY Act is not just dental, right? It's all healthcare professionals. So it's medical and dental. So that's why it's getting a little bit more bipartisan support, because it's not just about dentistry, it's the broader healthcare field in general. And as most of you, clearly know, with when students graduate, they have to do a residency. Even if you want to do primary care, if you want to do OBGYN, whatever you want to do, you have to do a residency. With dentistry, it's not required, it's elective. So, kind of building on what Dr. Grant said, if you are a dental student and you have gotten to the end of your dental school education, and you've incurred all this loan. We've already talked about 300, 500. I know recently when I was up in DC, I heard a student say they had acquired, I'm just shell shocked, so I can't even say it, $900,000 going into an ortho program out of dental school. I don't even know how, I can't even fathom that because I went to dental school so long ago, I guess, like some of us, but $900,000. So if a student wants to go into an ortho program or surgery program, the longer programs, or surgery 4 years, if you have $400,000, $500,000, even 300 that you're looking at, do you make the decision as a student? Oh, you know what? If the interest is not deferred, and with the READY Act, it basically is designed to pause both required payments and the interest accrual. So not just the interest that is accruing, but it actually pauses the payments as well. Kind of like if you remember during COVID, how federal student loans were paused for a while. When I did a residency, I don't recall, I actually recall the loan repayment period being deferred. Somewhere along the line that got reinstituted, right? So with the students in there, if I have to pay $300,000, am I going to make the decision? But I really am passionate about pediatric dentistry and I have to go do a 2-year program. Do I need to go make money real quick? So I just need to go work and, work for corporate America, or do I go into that pediatric residency program knowing that I have other life bills, other life things, and my interest is going to keep accruing? So it actually makes it harder for some students to decide if they want to go into a residency program, which is optional for dentistry, or if they want to go ahead and pursue that, with understanding, because the stipend is so low with a lot of these residency programs that you're not going to be able to pay those student loans back effectively when you're making such a low stipend, unless you go get another job or something like that. So, if we want more specialists, more faculty, and more dentists in underserved communities, especially specialists in underserved communities, then as Dr. Grant said, the whole idea of this bill is really to stop making residency a financial penalty, so to say.
So again, we see policy shaping not just finances, but actually career pathways and ultimately access to care. Dr. Greenlee Taylor, I'm proud to say that the NDA's Federal Baseline Dental Insurance Consumer Protection Act is a bold proposal. What problem is it solving at its core?
Yeah, so I know quite a few attendees probably are not familiar with this, but the National Dental Association, it's like, a lot of times with policies, you can be on the back end where you're advocating for it and supporting it, or you can be on the front end where you're helping to shape these policies. You're helping to actually content these policies and providing them to legislators to, help to get sponsors that will help take this forward. The National Dental Association Federal Baseline Dental Insurance Consumer Protection Act is basically, at its core, it's consumer rights. It's protecting consumer rights. So it's a lot. We don't want to call it the one big beautiful dental bill, but it's a lot in this bill, the proposal, not bill, but in this proposal, and it encompasses some parts of some other proposals that are out there, like the RISA. But at its core, it addresses the gap between having dental insurance and meaningful dental access. So too many patients technically have insurance, right? They have dental coverage, but their annual maximum is so low. A lot of you practicing over 34 years, I very rarely have seen dental insurance over $2,000. There's been like one or two that did not have an annual max, very, very limited, but most of them have capped at $1,000, $2,000. So at its very core, it basically says, look, we want to develop some type of legislation reform where the annual maximum, there's not an annual maximum, or the annual maximums are higher, more comparable to where we see with medical, insurance as well. There are a couple of different aspects of it. Like I said, it's an umbrella policy, basically. So it includes some mention of ERISA. I'll talk about that really quick because there are other proposals on ERISA. HR 7931, Improving Dental Administration Act. And ERISA is basically, if some of you are not familiar with it, it's the Federal Employee Retirement Income Security Act. So basically, if you think about, you have government funded insurance, Medicaid, that's all over here, but you have commercial insurance. You have two ways with commercial insurance. You have self-funded plans and you have fully funded plans. So for example, big corporations, I won't name corporations, but some big corporations, they may decide they want to offer their employees dental insurance, but instead of having a dental plan administered as fully and having the full risk, they actually take risk of it, but they hire a third-party administrator to actually administer that plan. So here's the difference. If it is a self-funded plan, meaning it's not fully funded and that corporation or that employer is taking the risk, a lot of the things that are important to providers, prompt payment, authorizations, virtual credit cards, some of the things that we have to go in at state level, like Georgia just approved, for example, a bill on virtual credit cards, mandating that with payers. Well, a federal policy basically does an umbrella where it's saying, okay, we want this consistency across the board, whether it's a fully funded plan or a self-funded plan, we want the same regulations to apply. So that's basically in the NDA proposal, components with that, and it's also in ERISA. A lot of times with federal policies, you will see a lot of overlap. You will see some bills introduced on the House side, you will see some bills introduced on the Senate side. And when you read both, a lot of them are aligned or comparable. And as the years pass, you may see the Dental Act of 2023, the Dental Act of 2025. There are a lot of overlapping bills on Medicaid and Medicare reform as well. So a lot of times you'll have an umbrella policy, and that's the intent, is like there's a lot of consumer protections in this. And at its core, it is a phenomenal proposal of, where we want to go with all of them, ensuring continuity and getting more access. You think a treatment plan. Somebody comes in and you give them a $10,000 treatment plan and their insurance ends at $2,000. What do you think they're going to do? Are they going to go with that treatment plan, or they're just going to get what the insurance will pay? So the key thing is having a dental insurance card does not mean access to care, is the bottom line with that.
And just to be clear, there is no federal baseline dental insurance. on the books or on the records there with the federal government. Dr. Grant, how would this proposed legislation change the experience for both patients and providers?
Well, first I have to say that Dr. Greenlee Taylor hit the nail on the head in terms of our maximums being so low. And it's important when you meet with legislators or when you're talking about policy to tell a story. So this is the story that happened today in relation to the question that Dr. Bellamy just posed. Went to my accountant to pick up my taxes, and her receptionist asked, said, Dr. Grant, why is my dental insurance cover so little? It's just so expensive. And I said, it's partly because the maximums are so low and the deductibles cause problems for individuals across the board, which, opened up this whole conversation. So is dental insurance really insurance? So what is being proposed would hopefully help to alleviate some of that gap. Insurance reform overall, what we hope for in insurance is that it would make health care available and accessible everywhere to everyone. So what the human aspect, this would make a greater dent in the accessibility of care. It would open up more viable conversations with between patients and doctors regarding their treatment plans and the alternative treatments that are real alternatives. Because sometimes when treatment plans are presented, we're obligated to present to our patients when we see them what it is they need, what we need to do to have them have good oral health. And when sometimes those treatment plans can be overwhelming, and yes, we offer alternatives, but we cannot offer less care. We cannot. And so that puts patients in the position, as Dr. Greenlee Taylor said, of having to choose and kind of ration out their health care from year to year. And we see it in practice. People, reach their maximum and then they don't come back until the next year or don't pursue their additional treatment until they have the new benefits from the new year. So that is no way to provide health care. It's just not. And we know it, and it frustrates us. So from the human aspect, Dr. Bellamy, just getting rid of the bureaucracy and having to do things by this time because this is what the insurance dictates would just make life easier, certainly, and better, certainly for our patients, but also for us as providers.
Great point, Dr. Grant. So I'd say it's fair to say that right now many patients have insurance, but they still don't have access to care. So let's spend a few moments discussing NDA's Day on the Hill, which is Thursday, May the 7th. When congressional members step up to the podium to answer questions or when we visit them in their offices, what message would we as NDA members deliver to members of Congress?
Scheduling a visit with our legislators or representatives is incredibly important and unfortunately so infrequently exercised by constituents and professionals. I think that sometimes people don't think about doing it or they're intimidated by it. And policy dictates so much of our lives, particularly as healthcare professionals, because we feel it from the policy, we feel it from the regulations, we feel it from the insurance companies. So this is something where we can actually have a voice. We don't have a lot of voice over insurance companies, but we can have a voice over insurance policy. We can have a voice over healthcare policy. We can have a voice on the importance of fluoride, community water fluoridation. Those are things we can do, and we know it. So it's not as hard or as intimidating as people might think. But in order to have an effective visit, it's an opportunity to share your knowledge, tell your story, and reasons for supporting certain legislation or programs. So an effective advocacy visit incorporates planning, scheduling, knowing your subject matter and the individual with whom you're meeting. And it is great when you schedule a meeting and your legislator is there, but very often it is their legislative aide who is there. And being very aware of your subject matter and also stating your ask. What is it you want? We support community water fluoridation. We support the READY Act and why. And finding common ground with the individual with whom you're speaking. It's really critical to follow up with supplemental materials and a thank you note and to stay in touch over time. Having that connection and utilizing that connection when you have information that might be useful, forward that to them. Schedule another time to meet with them, and they become very, very important. This communication pathway with the staffer or your legislator, because they'll come to know you, and they might and they'll come to know you and respect you over time, and might eventually use you as a resource or ask questions about dental care. Because you are the person that they've had the most contact with. And I've seen that happen where folks just say, well, this person talks about dentistry. Let me reach out to them. So those are just a few of the key aspects of meeting with your legislator and following up and becoming a resource for them.
Thank you, Dr. Grant. And I just wanted to mention that Dr. Nicholas Gordon, I want to reach out and say, hey, Dr. Gordon, reached out to us today and let us know that in Prince George's County and in Montgomery County, Maryland, the community fluoridation levels have dropped from 0.7 to 0.4. If you know, and we're all experts, or we should be really well versed on community water fluoridation, the minimum level is 0.6. So at a 0.4, it really is not doing anything. This could be because of the blockade that's going on in the Middle East, but it's important to let our legislators know that we are monitoring this. And for our community, a 0.4 level is just not adequate for protection for our vulnerable population. So it's important to get to our legislatures as soon as we see this. So thank you, Dr. Gordon, for giving that to our attention. Dr. Greenlee Taylor, what mistakes should we avoid when speaking with policymakers?
You saw my little prompt slide there, huh? Yeah. So
Good.
and I'll circle back to that on the fluoride just to talk a little bit about infrastructure and some of the advocacy points with that as well. But, Dr. Grant did a phenomenal job talking about, when you're there, what is the purpose? What's the goal? How do you go about it? For those that have been to NDA on the Hill, this is probably a refresher, but for those that may be new to NDA on the Hill, there's a couple of opportunities. What is the primary thing is that, we're in an event, we're in an event room, and there are legislators that come to us. We're educating, we're learning, we're all learning, we're educating each other. And then, as members of Congress come to speak with us or meet with us in our session, those are opportunities to ask questions as well. But then, as Dr. Grant said, there's an opportunity for you to set up meetings. You can basically go onto the United States Congress website. You can look up the staffer, we call them their staffers or their legislative assistants for who your senator is, who your representative of Congress is. And then you can call them and say, hey, I'm going to be in town. I would love to meet with, I'm a constituent of this senator, etc. And you set up an opportunity to meet with them. Oftentimes, the senator or the representative may not be in their office, but it's an opportunity to talk with their legislative assistant. And what I've learned through, my many years of policy, um, you know, sometimes the legislative assistant is the one that really is driving the policies because they're educating their representative or their senator with that. So those are the opportunities you have to engage and get involved. But when you are talking to them or you are asking questions or you are trying to educate, just three little quick things. A lot of times, you know, don't make it, and say this sensitive, don't make it a dentist only issue, right? For many of you have been in here, this is something we've been, I know in every platform I've served in, this has been an ongoing battle, where unfortunately dentistry or dental or oral health sometimes is not regarded as high as medical health or behavioral health or a lot of things that seem to make it up higher in legislative acts. So tie it in. Don't make it a dentist only issue. This is, about your patients, your family, your employers, the communities. And then second, do not lead with jargon. Policymakers need plain language and concrete examples. So yes, you want data and facts, but you also want storytelling to frame the narrative about your patients. What are some situations you had a diabetic patient and you got better, once you did periodontal treatment or something. You have to have the narrative of storytelling to really kind of make it more personalized and as Dr. Grant said, humanized, right? So, and then third, do not ask for everything at once without a clear implementation path. So the strongest advocacy pairs, a compelling human story with a practical policy solution, clear financing, and then a realistic roadmap. Interesting, years ago when I was working on my MPH at Emory, I learned deep dive into policy. I always knew a little bit about it, but I deep dive into it. And it was baffling to me when I learned that only 2% to 7% of legislative policies, are passed. And so to give you just a clear example, so I say that to say a lot of the policies that we educate on, advocate about, you're going to see so many policies. We've only talked about a couple of them, but there are hundreds of policies out there. If you read a lot of them, there may be connections to our profession, there may be connections to oral health, there may be connections not directly, but indirectly to that. But really, you can spend all this time, but only 2 to 7% pass. Like the 118th Congress that ended in 2023, think of it like this, only three, it's getting a little bit harder than it was, but only 3% passed. So 614 of 19,315 proposals were enacted into law. So that's why I say, you have to kind of, we're saying, eat an elephant one bite at a time. So you have to kind of break it down so, they can really understand with that.
Awesome. That's a great overview on how to talk to and speak to the advocacy or speak on advocacy to the policymakers. We have this is a time check, about 15 minutes left in our podcast webinar. Are there any other policies either of you would like to touch on before we begin to wrap up?
Dr. Bellamy, I think we'd like to talk a little bit about fluoride, and then I can talk about some of the Hill Day priorities for this coming Hill Day,
Absolutely.
if that is okay. And again, thank you, Dr. Gordon, for sharing the information about the change of I believe it was their name of the Department of Public Works in Prince George's County and Montgomery County, lowering the fluoride concentration in their community water. And I did listen to the newscast link that you provided and looked up a little bit of information. It does seem that their supplies are somehow being impacted by the conflict in the Middle East. Surrounding communities have not had the same impact, but it seems to have been their supplier. And it just brings up the importance of how interconnected so many things are. We sometimes just don't think that something that happens very far away is going to impact us and so immediately impact us. And here is a case in point. Dr. Bellamy, you may recall that when we opened this discussion, you asked what I thought was one of the greatest threats and opportunities. And I had said pseudoscience to me is one of the greatest threats to healthcare. And I would say even more than healthcare, just lifestyle altogether. And we are the experts in oral health. We understand our ethical obligations regarding non-maleficence, beneficence, and justice for our patients and veracity. And we have to be rooted in good science and promote those things that we know are good and healthy for our patients. So we, out of our framework, have to make certain that we do the things we know should be done to promote good health for our patients. So I'm a big fluoride advocate. We have had a tremendous fluoride statement on our website, and we have got to do our part to continue to fight this battle that we're in right now in terms of preventive care. We have a tremendous capacity problem in healthcare overall. If somehow a miracle happened and everybody in the country had health benefits and could obtain their preventive care and all the treatment they needed. We do not have the resources to do that. So we have a tremendous capacity problem, even for those who are insured. So by expanding our workforce, number one, but certainly addressing what we know are known, proven efficacious methods of prevention, such as community water fluoridation, I cannot speak more strongly about. So I just wanted to bring that up, and especially in relation to the information that Dr. Gordon provided us. We have to be ever vigilant, because when there are infringements on our professionalism, when there are infringements on our ability to provide the best care and to provide the best information and to have access to the best treatment, it is a travesty. And we need to be strong in certainly supporting good science and supporting prevention and advancing our profession as best we can.
Awesome. Anything you wanted to say about Medicare, Medicaid, dental vision hearing by Senator Also Brooks, or the oral health care products from Mr. Van Drew from New Jersey, or the dental loan repayment from Van Drew and Clark?
So I am very pleased to say that Senator Angela Also Brooks, a Marylander, and I am from Maryland, has proposed Senate Bill 2084, the Medicare and Medicaid Dental Vision and Hearing Benefit Act of 2025. And as Dr. Greenlee Taylor stated, these bills sometimes go over from year to year with their sponsors and co-sponsors. I'm especially pleased because not only am I a general dentist, but I'm also a speech and language pathologist. So I'm very happy to see the hearing benefit included as well. And this bill supports expansion of dental benefits to underserved and vulnerable communities, including our elders, and would require Medicare coverage of dental, vision, and hearing services, such as routine dental cleanings and exams, basic and major dental services, and emergency dental care and dentures. So it's an expansive bill that would provide more comprehensive care for our seniors and adults. And I look forward, we are hopeful that Senator Also Brooks will be able to visit with us on our Hill Day. We have extended an invitation for her to come and visit with us. I think you asked me about the, was it the Oral Health Products Inclusion?
Products Inclusion Act. And before you get to that one, Dr. Grant, just one other key point with the Medicaid, Medicare one, it also would increase the federal medical assistance, basically the percentage map. This is important, like for Medicaid programs, because, for example, using Georgia as an example, like when a decision was made to increase or fund adult dental benefits, the state would usually fund a certain amount. And then by legislation, by law, the federal will do what's called a match, a percent match. So if the state says they're going to, invest 11 million, for example, it's not the exact number, but 11 million in adult dental benefits, then the federal will do a percent match with that. So what this particular bill does, it increases that match to 90%. So it's never really been that high. So that's very important because then that provides additional funding when a state decides to do something. That federal medical assistance percentage increases, and then you get either double the funding, at 90%. Before it was like 50% or even lower. So that's a great thing with that part too. Just picking back, because I know we had a couple of questions in the thing I know you want to try to get to on the fluoride. I think it's very important. It's not a policy, it's not legislation, but it's very important as we're educating and informing our legislators. We do have to still advocate for them to help. We want them to advocate this administration to restore our leadership, our dental leadership in these agencies. Part of the fluoride issues, we no longer have a CDC or a health division. So we don't have anyone kind of with the science and all of the things that help kind of move that. We do not have a CDC division, for oral health anymore. HRSA is gone. The only agency that still has a chief dental officer, a chief leader, is the National Institutes of Health Dental Craniofacial Research. HRSA is gone, chief dental officer. So it's very important that we encourage our senators and our representatives to help encourage members of this administration to restore dental leadership in these agencies, because that's what helps move the science along and move the data along. Just wanted to add that part in there.
I appreciate that tremendously, and reminding folks that the CDC Division of Oral Health was dismantled about a year ago, actually. I think it was like April 4th of 2025, which, and so much at the CDC, especially in regarding prevention and tobacco use, has just been decimated. So that was a strong arm of our guidance and recommendations in dentistry to have lost the Division of Oral Health. I did have a question about the match, because this is just kind of been lingering in the back of my head. For those states that didn't do the Medicaid expansion, I think there were about 10 states, they would not be eligible. Would they be eligible for the match? Because I would think they would not be, because they didn't expand.
Yeah, it depends on if it's for expansion or if it's just for more additional funding for the medical assistance programs in there. Yep.
Okay. That was lingering with me.
Right, right.
It's going to be one of my questions with Senator Brooks also.
And I don't know if you wanted to touch on the Inclusion Act in 1 second.
Yeah, go ahead.
No, I said you. Yeah, I think he wanted you. He wanted you to touch on it.
Yes, I was just going to talk about the Oral Health Products Inclusion Act, whose purpose is to include over-the-counter oral health care products as qualified medical expenses, which can be purchased with health savings accounts and flexible spending accounts. So for those individuals who have FSAs with their job, they've not been able to use these funds for things like floss and toothbrushes and electric toothbrushes and water flossers. So this is, a great, because oftentimes when people have an FSA, they're at the end of the year really trying to maximize and make sure they've utilized everything that they put away. So these oral health care products would be included in FSAs. And this bill, this is HR 1219 and is sponsored by Jeff Randrew, who is a dentist from New Jersey. So that's something that is certainly on our line of sight in for Hill Day. And Dr. Bellamy also mentioned the Dental Loan Repayment Assistance Act, and this is sponsored by, again, Representative Van Drew and also Yvette Clark, so it's bipartisan. The Dental Loan Repayment Assistance Act will allow full-time faculty who are teaching and practicing in dental clinics located in dental schools, hospitals, or community-based affiliated sites to exclude from their federal income tax the amount of loan forgiveness from their federal student loans. Consequently, these loan assistance benefits would not continue to count as taxable income. So for those who didn't know, if folks were getting this loan forgiveness, they were still having to be taxed on it, which is really absurd. But it is what we are dealing with, and there's actually an attempt to ameliorate this issue in a nutshell. I would just like to, I know we're coming up on our time, and I do note that in this meeting, convening this podcast, the 80-second, 90-second, and 100-second presidents are here. So this is 10-year span. But I want to say NDA Hill Day, the first Hill Day was in 1999. And in 2009, former Senator Benjamin Cardin and former Congressman Elijah Cummings recognized, and I have it here in this really official folder, the individuals who were at that first Hill Day, who founded Hill Day in 1999. So in 2009, they wrote, I'm not going to read the whole thing, but members of Congress have come to greatly appreciate this program for its content and for the commitment demonstrated by the National Dental Association to its overarching mission, elevating the health and oral health status of persons in underserved communities. The NDA is a role model for all who are dedicated to improving health across and access and eliminating health disparities. I just wanted to kind of make sure we got that in because it was so nice to be recognized by stalwarts and great advocates of oral health and healthcare period, but particularly oral health in our nation. It was just kind of, I thought, oh, let me bring this to this podcast. Anyway, thank you for allowing me that moment, Dr. Bellamy, to kind of reminisce about the past and our origins.
You're very welcome. And it's good to see that policymakers do listen to you as advocates and as professionals and as experts in your field. So let's tie a bow in this. Dr. Grant, in one sentence, what's at stake at Day on the Hill?
So we have to come together and understand that policy matters and that we can actually affect the perceptions our policymakers have about healthcare, about our profession, and about even their communities, because sometimes they are clueless about the inability of their communities to access dental care. And we must get this right so that the health and healthcare of our families, our communities, and our nation is not in jeopardy, but is still instead is optimal, accessible, and affordable.
Awesome. So Dr. Greenlee Taylor, in one sentence.
Yeah, mine says less than a sentence. We have to keep the importance of oral health to the forefront because it's so vital to overall health. And we just have to tell the story a little bit better so everyone listens. I guess that was a sentence. So there we are with that.
This is a defining moment in our profession. At the beginning of this conversation this evening, we said that policy is more than policy. It's about people, and it's about who has the opportunity to enter this profession, who we become as providers, and whether the patients we serve can truly access the care that they need. Tonight, we've made one thing clear. It's that decisions being made right now will shape the future of this profession and oral health care in this country. So, if we want a future where access is real, where workforce is strong, diverse, and sustainable, and where patients are truly protected, then we simply must show up as advocates, as a unified voice. Before we close, I want to extend my sincere thanks to my two extraordinary leaders who helped guide this important discussion, Dr. Leslie E. Grant, Chairwoman of the NDA Legislative Committee and number 82 and the past presidents of the National Dental Association, and Dr. Judy Greenlee Taylor, member of the Legislative Committee, policy expert, and the 92nd past president of the National Dental Association. Thank you both for your leadership, your insight, your unwavering commitment to advancing our profession and the communities that we serve. So, May 7th, it's a responsibility. It's a responsibility to our profession. It's a responsibility to our communities. And it's a responsibility to the generations that follow us. Let's meet that moment as one. Thank you for joining us for the National Dental Association's Policy Hour. I'm Dr. Wallace Bellamy, and on behalf of the NDA, I want to thank you for being part of this important conversation and for your commitment to advancing oral health equity and advocacy. We look forward to seeing you on May 7th for the NDA Day on the Hill in Washington, D.C., as we continue this work together. So until next time, stay informed, stay engaged, continue to be a voice for our profession and the patients we serve.